We will continue our lecture with the other part, and we will talk about investigations for infective endocarditis. And we have to know that blood culture is one of the most important investigations for a patient with suspected infective endocarditis to identify the causative organism and to guide the antibiotic therapy. We have to take from 3 to 6 sets of blood cultures before starting antibiotics. Echocardiography detects vegetations, assess valvular affection, ventricular function, and abscess formation. This is the vegetation, which is formed from the infective organism, platelets, and fibrin deposition. Vegetations as small as 2 to 4 millimeter could be detected by transthoracic echocardiography, and we can detect even smaller vegetations by transesophageal echocardiography, which is particularly valuable in identification of abscess formation and in investigations of patients with prosthetic valves. Other investigations like elevated ESR, CRB, and leukocytosis, normostatic normochromic anemia, and it's important to have ECG to search for AV nodal block. Diagnostic criteria for infective endocarditis or modified Duke criteria. We have definite diagnosis of infective endocarditis if we have 2 major criteria, or 1 major and 3 minor criteria, or 5 minor criteria, or possible diagnosis of infective endocarditis if we have 1 major criterion or 1 minor, or if you have 1 major and 1 minor criterion, or 3 minor criteria. The major criteria are positive blood culture with typical organism from 2 cultures, as if we have positive culture for Staphylococcus aureus twice, or persistent positive culture taken more than 12 hours apart, or if we have 3 or more positive cultures taken over more than 1 hour. Other major criterion is the endocardial involvement with positive vegetations in the echocardiography or new valvular regurgitation. While the minor criteria are the presence of predisposing valvular or cardiac abnormality, intravenous drug abuse, fever more than 38 degrees, presence of one of the embolic phenomenon, presence of one of the vasculitic phenomenon, or suggestive echocardiographic or blood culture findings that are not consistent with the criteria of the major criteria. The treatment: we have a preventive measures, antibiotic therapy, either empirical or specific antibiotic therapy, and surgical treatment. The preventive measures: we have to prevent infective endocarditis through good oral hygiene, treatment of any potential source of bacteremia, while routine antibiotic prophylaxis before interventions is not recommended except in specific conditions, like patients with prosthetic valves or previous infective endocarditis undergoing dental procedure. Empirical treatment for infective endocarditis is decided according to mode of presentation, suspected organism, presence of native or prosthetic valve, and according to penicillin allergy. If we have acute form of infective endocarditis, we can start empirically with flucloxacillin and gentamicin, as the suspected organism is Staphylococcus aureus. If we have a subacute infective endocarditis, we can start empirically with benzyl penicillin and gentamicin, as the suspected organism is streptococci. If we have penicillin allergy or suspected methicillin resistant Staph aureus, we can start empirically with vancomycin and gentamicin. If we have prosthetic valve, we can start empirically with vancomycin, gentamicin plus oral rifampicin. Specific treatment. It's important to note that we start empirical antibiotics before the results of blood culture. After the results of blood culture, we can start specific treatment according to the sensitivity. Streptococci. It's important to know that streptococcal infection could be treated with benzyl penicillin IV and gentamicin, and according to the minimal inhibitory concentration and the presence of native or prosthetic valve, we could decide the duration of treatment, which is 4 weeks of benzyl penicillin in native valve endocarditis and 6 weeks in prosthetic valves, regardless the minimal inhibitory concentration. 4 weeks for native valves and 6 weeks for prosthetic valves, while the difference is in the duration of gentamicin IV according to the minimal inhibitory concentration. Staphylococcus infection according to penicillin sensitivity and methicillin sensitivity. If the patient is penicillin sensitive, benzyl penicillin IV for 4 weeks in native valves and 6 weeks in prosthetic valves. If the patient staphylococci are penicillin resistant and methicillin sensitive, we can go for flucloxacillin, 4 weeks in native valves and 6 weeks in prosthetic valves. If the patient staphylococci are resistant to penicillin and methicillin, we can go for vancomycin IV and gentamicin IV for 4 weeks in native valves and 6 weeks in prosthetic valves. Surgical treatment. When we have to go for surgical treatment, if the patient develops heart failure due to valve damage, if there is failure of antibiotic therapy to control infection, if there is large vegetations on the left-sided heart valves, the mitral or aortic valve, with evidence or high risk of systemic embolization. And thank you.